Oh, thank you, Scott, so much. And it's really wonderful to be here with you all today. Excuse me. And yeah, I've been working in this field, came out from Drexel, a little, green behind the ears, even though I worked through my practicums, and that was a while ago in 1996. And so I've been doing this a little while. But I do have to admit, as David Covington, who is, kind of one of the founders of Zero Suicide, talks about that first call when somebody calls and you're sitting face to face with them. And there was a young lady I was in the inpatient unit with, and she, now, of course, this is for the benefit of us learning together today. Normally we don't talk a lot about means, but here, today talking together, and she had cut her neck so severely that it was being held together, and I'm sitting here and I'm looking at her and I'm thinking, what did I learn about suicide again? Because all of that knowledge goes out the window. And here I was, 22 years old with my master's degree, trying to figure out how I was going to help this woman in the inpatient hospital. And there we are, excuse me. And so this is today about healthcare and suicide prevention, and what does it look like when we go from suicide prevention, which is largely thought of for many years anyways, as being something that's done in the community. And what does it look like when we start thinking, wait a minute, what does suicide prevention care look like in our healthcare settings, in our emergency departments, in our behavioral health settings, in our substance use settings, and in our inpatient and health crisis system settings. Excuse me. So that's really what we're here to talk about today. And thank you so much to Scott and the McLeods for asking me to come and speak with you all today. It's very exciting to think of when counties come together. That's actually my favorite. I think that's one of the best ways that we can really look, excuse me, I don't, really think about getting at suicide prevention all the way around is from a county perspective. And so that's one of the strongest ways that I've seen healthcare systems come together and systems of care to really stamp out suicide. And so, as Scott mentioned, I'm from the Office of Mental Health Suicide Prevention Center. And we're here to talk about this call to action. And so, excuse me. Well, I am sharing my screen and I am trying to make it go. Scott, it says I'm the one doing it. Oh, here we go. All right, it finally worked. Okay, so our time together today, I had an agenda handed to me of some of the things that we might want to look at based on where you're all coming from. And so we thought it might be best to do a little bit of a 101 on zero suicide. And that's just meant as a blanket for everybody. Don't want to assume where everybody is on the continuum of understanding that. So we're just going to go straight into the beginning. It's always good to look at the suicide data and research, just a peek into it. We don't have a lot of time together today. And national and state information, where it stands today, kind of that 50,000 foot look at how this affects what we're talking about today. And then suicide as being a public health problem, excuse me. So, and then, kind of what we might be asking ourselves today here, what does this have to do with my agency? Why would we be a part of this? And then I hope to share with you some opportunities and some resources at the end that you may or may not be familiar with. So a call to action, that's the name of our time together today. And so it's always just good to start and look things up in the old Merriam-Webster's dictionary. And I was kind of excited when I looked at it. It said to, communicate emphatically. So I'm good at emphatic. Excuse me. But Zoom is a whole nother beast. If we were in person, it would be a lot easier, because I like to walk around the room and wave my arms and come sit by you. So you may be glad that I can't do any of those things. But if you stick around, maybe we'll see each other in June, and we'll, COVID willing, be able to all be together face to face. But this is and we have this little graphic on the edge. I just liked it, but please don't hashtag that for today's event, because that's not related to us. So just a word to the wise on that, if you're a hashtagger. But it really is about this call to action. And what do we kind of really mean by that? But it's us coming together today and stimulating, inspiring, to do something. Inertia is a thing, right? But bodies in motion like to stay in motion, right? So there's these laws of physics, these laws of how things work. And once we can kind of get unstuck or get into a rhythm, or kind of get things going, then I believe just by getting started today, or maybe getting re-energized, or just hey, this rhymes with the flow I'm already doing, whatever it is, we've got to keep moving, we've got to go forward. And that's what this call to action is about, is like, get in the flow with us. We're already going, like the zero suicide movement is massive, and it's flowing and it's going, and you can just jump right into the flow with us. And so this is me calling you. And so today we're going to try to move through that. And I do love the other part of this. I thought this is actually perfect for what we're talking about. So I don't know if you can, well, you can move the people. I'm going to move the people. Excuse me. So but it's also in order to achieve an aim. And this is exactly, we're going to do the definition of zero suicide here in a moment, but we really do have an aim. We really are trying to look at this aspirational goal of decreasing the deaths of suicide within the people within our care, or the people that recently leave our care. Are we willing to take responsibility for the people that have been in our services the 24 hours after they leave, or the 48, or the month after they leave our services? Are they still our responsibility because they came to us and they were in crisis, or they had a suicide attempt, or they were having suicidal thoughts that plagued them so harsh that they had to come in for care, or while they were here, they began them? These are the kinds of questions that can become involved. And so this is a problem. And I think that you would all agree with that. So let's take a minute to look at the toll of suicide. We had a report come out of the Office of Mental Health of our division here. And this was our suicide prevention plan. It still stays now. We're updating it now, but it's called 1,700 Too Many, because those are the lives that are lost to suicide in New York. And so when we talk about it being a public health crisis, what that means is that this is looking at deaths that are preventable. So in the public as a whole, when you can do something to prevent a death from happening, then we call it a preventable death. And what we mean by that is not that any of us could have stopped somebody that we love from dying by our single efforts. And that's where it can get kind of difficult with suicide, because it really can be on our hearts and our minds that there's something that we really could have done as individuals. But this is really looking at the bigger picture as far as the public as a whole. And if the public were more armed with the facts, if the society as a whole, if a system as a whole, your hospital system or your agency or your organization were trained, that you had a skilled workforce when it came to suicide. They weren't like me sitting there looking at this woman in the psychiatric emergency room going, oh my God, I can't look past her neck. How could I even ever help her, like a deer in the headlights at age 22? Can we have a skilled workforce that knows how to intervene with suicide, knows what to say, feels comfortable saying it, can ask directly about suicide, and has the training to do so? They have the tools to take care of people that are suicidal and their families, that it's culturally competent, And they had the support of their supervisor. All of this is part of the zero suicide bundled approach of best practices. Excuse me. And so when we look at this, I can tell you that in the healthcare systems in the United States, the answer is no. The normal healthcare system does not have that. And so we do have this real public health crisis, and the normal, whatever normal is, the basic community in the United States does not have a public health answer to the cry of suicide, where they have the trainings that are needed in the community in all the different places, when they have a general understanding that treatment is out there and that hope is available and that treatment works. That's not the message that the majority of communities are giving. And so that's where we say we have a public health crisis with suicide, because the suicide rates continue to go up. Though we did see some preliminary data from the CDC that came out, what was that, just maybe 3 weeks ago, that it may have gone down in 2020 during COVID. And so that'll be very interesting to see what happens, what age groups that was. That data isn't, what do you call that, verified yet, that, through the CDC cleaning process. But it's still great news. It'll be wonderful to see kind of where that, what are the things that were in place that really made that change. I have my own thoughts, but let's not get into that now. So what we do know about suicide in New York, in the United States, and in Tompkins County, is that it, well, I'm not gonna say that in Tompkins County because I don't think your medical director has a website. I wasn't able to find anything. You may just have a coroner's office. That it is the 10th leading cause of death in the United States, and it is the 12th leading cause of death in New York. But let's take a look here. And this is a lot to look at, so I'm apologize right up front if you don't spend a lot of time looking at death charts, which I'm assuming none of you do. This is, let me just show you over here. This is the deaths being ranked from, from 1 to 10 over on the left-hand side. So the first cause of death is over here on the left. This is age 1 across the top, ages 10 to 14, 15 to 24, 24 to 34. They're just clumped into some of these general groups up here across the top. And then on the far right, you have all ages. And so that if we look at the #1 cause of death in 10 to 14-year-olds is unintentional injuries. And the second leading cause of death is suicide. Ages 15 to 24, the second leading cause of death is suicide. 25 to 34, suicide. 35 to 44, suicide is the 4th leading cause of death. 45 to 54, the 5th leading cause is suicide. Now, when you get to 55 to 64, it drops down into the 8th leading cause of death. And then it's hard to find on 65. And then you get to all ages, it is the 10th leading cause of death. Now, you can see it's above homicide, and it's right below unintentional injuries, which we don't really have time to talk about, but a lot of those are probably suicides. What I do want to point out, though, here, let's go to New York. No, wait, just a second. I have this bar at the top here. I don't want this here. Well, anyways, is that when you take out some of these things like cancer, respiratory diseases, liver disease, cerebrovascular diseases that are not preventable, Alzheimer's, your suicide deaths rise up to be 2nd or 1st in these other ages. So you're really looking at suicide as being the 1st or 2nd preventable cause of death across most age groups. And so I can't see what's out there. But anyways, I know one of you guys is smarter and can tell me how to move that. So anyways, and then for New York, we've got the same thing happening. Over here, it's the 2nd leading cause of death in 10 to 14, I mean the 3rd, and then the 2nd in 15 at 25, and then jumps down to the 3rd. But here again, we have cancer, we have heart disease, being the #1 and 2nd leading cause of deaths over here, and the flu. So you can see again, preventable causes of death, you can see that suicide really is much higher up. So then when we look at like Tompkins County, I just pulled some of your census data so we could get a sense of y'all. And so you're about 105,000 people living there, according to the census data from 2019. And so when I just looked at some of the basic demographics there, you've got 50% of you are female to male. And then about 67% of the people that live there in Tompkins County are ages 19 to 64. Now, I'm not showing you all this to get all hung up in population data, but just to help get a sense of these basic population data in relationship to your death data, if that makes sense, in relationship to New York. And then if you have a chance within your agencies, ultimately, these are some of the ways that you could start to understand who's dying by suicide or who's coming into your care and who you could be watching out for. So I don't want to get hung up on it, but these are some of the things that people like me think about. And so these are some of the different races that are made up. So when you think about, so you've got basically 50% female to male, okay. You've got this, most people are between these ages here. And then you've got all these different races represented here in your county. It does look like the majority of the races represented are white alone. And so I went ahead and thought, well, let's pull this from the data over here. And so this is actually white males. I pulled for New York to get a sense, since that seems to be the majority of the people in your county, just to see what might happen over here. And we see that it's the 8th leading cause of death in New York State for males for all ages. So I'm just giving you a sense that you can do all of this type of thing once you have that kind of data, and you can get a sense of who you're looking at. It can help to narrow things down. So I couldn't do a lot of population data with you guys, but thank you to Scott. We did have some other data about Tompkins, but you've got about 12 suicides per year. And so the other thing to think about is, there's a lot of suffering suicide beyond that, which of course then Scott goes into letting us know about, depending on which statistic you look at, how many people per one death are affected. And it is quite a lot. It's not, so it's all of the family members or the people that loved or were friends with the person who died, but as well as what I've been seeing recently is who were the first responders on the scene, who are the people that are the responders each time that there's a suicide or a death. It affects those folks, it affects the people at the hospitals that treat the people who ultimately end up dying by suicide as well. So there really is this larger community effect. And then we kind of have our national rates where we can look at how many people are possibly attempting suicide each year. And then when you start talking about thoughts of suicide and being plagued by thinking about suicide, that just gets even more and more people are affected. So, if you've got 100,000, you've likely got, several thousand people really suffering suicide in your county now as you speak. And what this brings us to, though, again, this idea that suicide is preventable, and it's do you believe that? Do the people that you interact with believe this? And so it's really taking this mantle on within ourselves and within our agencies. It doesn't take, if you've ever worked with, I'll just use this example with adolescents, they can tell immediately if you believe what you're talking about. They just have this sense, and many people can, but it just seems to me like adolescents, they can tell, so anyways, that's like a neurological thing, like mirror neurons and all this stuff, but really, they can just tell. And so it's it's walking like the walk, right? Not just talking the talk. So whatever we need to do within ourselves. And so one way, is fine, have a trained and skilled workforce. Like I said, there are trainings out there that help people, staff and whoever takes it, interact with their own biases and feelings and thoughts about suicide. And so that's part of being a suicide savvy workforce, right? Is having these types of trainings and having the opportunity for your staff or yourselves to be able to walk through those biases, those implicit biases that we might have. We can start to see that actually suicide is preventable. It's preventable for people that we have within our care, for all patients. And I wrote this on there, and we have, I think the nice term that I heard being used more the last time I checked was super users, but that's people who come through the system frequently or quite a lot. And which is referred to offhandedly as frequent flyers a lot. And that hopefully you don't say that, but I mean, inevitably people end up saying terms and utilizing, kind of negative phraseology when they get, up into a system or burned out or, excuse me. Then there's just this idea that suicide is preventable for everybody, not just adolescents, not just older people, but also veterans, also mothers, also, young children. And so it's really everyone. We really have to get to the point where we can think suicide is preventable for everyone, so that when we see somebody in the emergency department says they're suicidal, we can believe them. We don't find our people dismissing people, right? Just based on these biases that are within us that we don't even realize. And then this idea that there's a campaign out there nationally and federally that says, where they're talking about everybody has a role to play in suicide prevention. And this is something else that has to do with the zero suicide concept, is that everyone has a role to play. We just have to help people find what it is. And so within this idea of a systems approach, we can start thinking of, well, what is my role and what is the role of the different departments in my agency? Excuse me. All right, can I not do this when I don't? There we go. So the idea of zero suicide, for me, and for many, the underpinnings came from this report here, Suicide Care and Systems Framework. I don't know if anybody's read it. I don't know if you need to at this point, but this is, I sat in my small little office, with no window, there's a little broom closet, and read this when it first came out. And Fred Meservey, actually, from New York, from SPCNY, was one of the largest writers and contributors to it. And it was the Clinical Care and Intervention Task Force of the National Action Alliance, which is a public-private partnership. It's like a national and federal coalition, basically, is what it is. And it still exists today. And they don't call themselves the National Suicide Prevention Coalition for a reason. They call themselves the National Action Alliance for Suicide Prevention, because they really want it to be about action. And that they've done that consistently. They have work groups just for short periods of time. And they, like this one, they were the Clinical Care and Interventions work group. I got to sit in on a couple of calls, and I didn't say much, of course, sit in, and they were really the great minds of the time. And this was a state-of-the-art white paper when it came out, and they were talking about suicide care and systems. And this was really very new thinking at the time. It's like, we're going to take suicide prevention and put it into systems. And this is supposed to be a picture of the bridge, San Francisco Bridge. I did not know that for a very long time. I had no idea what this picture was. But, before that, and I don't know if you guys, been, I can, I mean, I'm not judging, but it looks to me like some of you guys have been around as long as I have, that, there really weren't standards and guidelines for suicide care, suicide prevention care, and clinical care for, the majority of my career, and many of yours probably. So when I read this, and it talked about emergency departments, hospitals, clinics, and crisis centers, and so forth, inpatient, what was being done at the time in those areas, and what probably should be done at those times, and what the gaps were. It was pretty mind-opening. And as somebody who had been working in the field, and I was new as a state coordinator, so this was 10 years ago, or 11 or 12 or something. Oh, you can do the math. It was 2011. Anyways, I had the opportunity to, take a look at this and to realize how important this really was, what these recommendations were calling for. And it was basically like healthcare reform for suicide within these systems, which is really what we continue to do. And so this came out at the same time as this national strategy for suicide prevention. And the reason I'm telling you all this, the national strategy and the state plan, go hand in hand. We have grants in the state for suicide prevention and zero suicide that go hand in hand with this as well, because the goals that come out of this are the goals of zero suicide, and they're about clinical care in settings like yours. And the goal is to make healthcare a priority, a core priority. Suicide, a core priority in healthcare is basically what this boils down to. And so at the time, you can see it was on CNN. It's like national news. Like, can you even believe that there had been all of this time where suicide wasn't a priority? I mean, it's just like absurd, really, if you think about it looking back. But I mean, that's where we were. Think about, all of the other, types of things that we have focused on in healthcare. Zero, and now here we are at zero errors. But to me, zero errors includes zero suicides, and that's one of the ways that I think about it. So we come to our definition here of zero suicide, and it's a layered thing here. There's more to it than just the name. It's really become a huge movement, is what it is. And so when people throw the name around, that's fine. But it's really what it is it was a beginning of all of these things I've been talking about, right? And so it is that aspirational goal that within a closed and boundaried system, there would be no death by suicide, right? We're not saying that in the United States, the number is going to go from 47,000 people die by suicide, or whatever the number was this year, to zero, right? What happened was, in the Henry Ford healthcare system, who was doing this at the very beginning, if you've ever been to any of Dr. Edward Coffey's lectures, where this kind of whole process began in practice, and a lot of the writing from the Systems of Care report that I just showed you is based on what happened there too. He talks about they're in the room and they're trying to come up with measures and metrics for perfect depression care. And they're like, well, what would it be if we were doing perfect depression care? What would be the best case outcome? And a nurse stands up in the back of the room and she says, well, if we were providing perfect depression care, nobody would die by suicide. And you could just hear a pin drop. It's like, right. Isn't that the worst case outcome in health and behavioral health care? A sentinel event on our watch? I mean, it really is. But we don't often measure that way. And so, that kind of became the standard there. And so when I read that, it's like, oh my gosh, what are we measuring? what what are our goals? And then the wonderful thing that came about after that, I just happened to be a part of things in the beginning. And so the best part about zero suicide is it's not just like pie in the sky thinking, it's also how to make the pie. So like it says here, it's this practical set of tools and strategies. It's a bundle of best practices that you use from the minute you meet the patient all the way through their intake, their time with you, they're getting ready to leave, and then the time they leave their care with you, and then you follow up with them. Like the entire continuum of care, you're providing this bundle of care around them the entire time, and that's the suicide care. And the way that you do that at each plot along the way is by following the zero suicide framework. And that's really what zero suicide is. And so I just kind of wrote this definition here based on the pretty general zero suicide definition. Excuse me. But it really is using the suicide care, the zero suicide framework to hang your suicide care around. And I put in there, it's really to enhance the and make safe the experience for your staff, for your system, and really ultimately for the people that we're giving care to and their families. And it's in this very collaborative way. And so I'll kind of explain that a little bit. And it seems maybe daunting, because transformational change often is. However, we're going to talk about that. And excuse me, I just wager that a lot of what you're doing, you're already doing this. Every single one of you is already dealing with suicide. You're already doing a lot of the things that are here that are part of it. And so it's just a matter of, sometimes we stand there as providers, I think, and we're like a lighthouse, and we stand there and we've got our doors open, we've got our beacon out, and it's like people can find us and they can come in because they can see the light out like the lighthouse, but then sometimes we have to take the light and turn around and shine it within ourselves, right? And I think that's what this is. These are those moments where we have to say, is suicide care a priority for us? What are we doing with transformational change around suicide? Are we there? And what do we need to learn? So I hope that's why you're here today. And I appreciate you being here because I know you're already doing a lot of this work. And so all we're doing is turning that light back around and kind of swinging it inside the house and looking around, is it cobwebs? I don't know. Excuse me. And so this is kind of the why of it. Excuse me. And if you were at our symposium a few weeks ago, you heard speakers much better than me, kind of really laying out why we do this. What is it that's unique about behavioral health and healthcare, emergency departments, inpatient, and primary care? It really is a unique touch point, because this is what we have found out through the research, is that 80% of folks who died by suicide had a healthcare visit in the year before their death. Whoa, missed opportunity, guys, and of that, 45% had a primary care visit in the month before their suicide death. Now, that's an area where, this is on all of us. This isn't on any single person. And this is something we're certainly working on at the state. 20% of people who died by suicide had contact with mental health services the month before they died. And 37% had an emergency department visit without any kind of primary diagnosis. And what that means is a primary kind of mental health diagnosis. So this is nationally, but this is consistent with what we found in New York as well. So then why zero suicide? I would think some of you have already been visited by the commission, the Joint Commission. If you went to Dr. Ed Bordeaux's talk at the Zero Suicide Symposium we had, or you can go and read it. There's information in here about it. You'll find that he was already leading a very intense zero suicide effort in his emergency department at UMass when they were visited by the Joint Commission. And it was like pulling teeth, though. He was having a hard time getting all the buy-in that he needed. And they had that visit and they got dinged quite severely on suicide. And so, of course, he was embarrassed. He talks about it himself, but his agency got right on board. And so, I mean, unfortunately, it's often, what is it? I mean, this is just my experience. Correct me if I'm wrong. It's often a lawsuit, a sentinel event, or a, bad findings from a Joint Commission review that'll, or whatever your, card for whatever your certification is that you need to maintain your business, that'll get the system moving. So all I'm saying is that it's coming anyways. So it's something to think about as a reason to join up. If the reasons that I had already mentioned before this, the return on investment, if I have any CFOs in the room, is actually quite good. Excuse me, Dr. Brian Amadani, who's the lead on zero suicide at the Henry Ford Health Clinic. A million, I want to say millions. I think it probably is. They're for profit, but I always tease him about that. But he said their entire zero suicide project pays for itself. And there, excuse me, there is research on that on the zero suicide website about the return on investment case. And so this is not a losing money situation at all. And our survivors of suicide loss, people who have loved people and lost them to suicide, people with lived experiences of suicide attempts, and this idea of value-based care, excuse me, they will tell you about zero suicide, huge fans of, excuse me, feeling supported and cared for through several of the sections of this more collaborative way of being, and also feeling, kind of more carried and supported through the entire process. And ultimately, of course, the do no harm. Effective care for the right problem. Has anybody here ever, your own experiences, like detached from, thinking about your agency for a moment, have you ever had effective care for the right problem? Have you ever had bad care? Have you ever taken one of your kids in and not gotten the care that they needed? And so I had a friend who took her son in and got a x-ray and everything, and walked around on a broken ankle for 3 more weeks. So that happens. I mean, we all know that things like that happen. But have you ever had excellent care, and how that makes you feel, with an aging mom, to know that she got what she really needed? It's such a difference. And when you start talking about something like suicide care, it makes all the difference in the world. And so this is where we start talking about suicide care and patient safety. So safer care for suicide is patient safety, right? Because we're bringing all of the measures that you would be bringing for any other patient safety cause in your work, and we're just bringing it into the mental health side and asking for that same equity. So Michael Hogan was our former commissioner of a couple of different states. He's also one of the main authors of all of the zero suicide literature and work. I've worked with him for several years, zero suicide faculty, but I really love this quote from him. We should treat suicide prevention in the healthcare systems as we treat heart attack prevention. In fact, that's where I kind of, what do we call care and patient safety efforts for people with suicide risk? And that's where I kind of started thinking about it, back many years ago, is, okay, so you come in and you want to get help. Something's wrong. You get a screening, right? When you go in for care, you get an assessment. If you've screened, like oh, something is wrong. Like there was a screening and it showed something was wrong. Okay, let's do a further assessment. Okay, we do have something going on here. Okay, bring in the family. We need to talk, right? All right, we're going to have a plan now. We're going to have what we call, we're going to have a plan. And then based on that, we're actually going to do an elevated level of care. And you're actually going to need to get some treatments. And we're going to follow up with you. Okay, so we have that in diabetes care, cancer care, and in suicide care. So that's why I started calling it suicide care, because that's exactly what you would do. And that's exactly what you do in the zero suicide framework. What I just said, it's the exact same thing. We just have all these different ways that we teach it, and you learn all the different methods and tools. But just how you treat all those other things, those exact same things I said, that's exactly what zero suicide is. So having standards for healthcare and suicide prevention, as I said, has been a long time coming. In 2018, I think it was released in 2019, Mike Hogan and Julie Goldstein Grummet, she's the head of Zero Suicide Institute at the Education and Development Center, wrote this report from the National Action Alliance, again, recommended standards for people with suicide risk. I think this is a very important document, excuse me, and we're not going to get into it now. I just wanted to make sure that you guys started to understand that these are the types of things that can help in preparing for a Joint Commission type of visit around these types of things. It's very practical information. It lays out a lot of what I've been talking about, but just not in maybe so much detail or in just a little bit different of a way. And so here we come to the actual elements of zero suicide. So we have the leadership element of the framework, the training element, identification element, engagement element, the treatment element, the transitioning and care element, and then the quality improvement element. And so each one of these is, a lecture in its own right. Of course, which of course we're not going to get into today. Because we're really here to talk more about kind of what is zero suicide and some of those types of things. So I didn't want to get into a big talk about all the elements today, though I'm happy to, at a future time. But what I can say from going around across the US and talking to lots of different types of systems and lots of different states and lots of different folks over the last, I don't know, since 2013, that, excuse me, that this can absolutely be done. This is, difficult when you stand here and you look at all of these and you think, what are these? How does this work? But it absolutely can be done. When we talk about leadership, we're talking about buy-in from the top down, right? We have to have leaders. That's why you're here today. If I was to set about when I was in that office, all green, and said I wanted to do something, about suicide prevention, they would say, that's great, kid, run with it. And it would get so far, right? Because without every level of the agency working together with a consistent message and plan, then you all know it's doomed to fail, right? And so, and having been over all the clinical parts of a large health administration before I started this work, I also know that things that they don't know. So it's really got to come from the top down, that message. And the way that I also have liked to think about it over the years is the power and the passion. Also got to go back and find your natural leaders at the agency, who if that nurse manager is on board, it's going to fly. And if they're not, it's not going to fly, so you've got to know who your people are, but also who your champions are, who your passionate people are that have a love for suicide prevention, or who just get passionate about things that are going to help your organization. There's always people like that. And getting them involved so that you have the power and the passion. You have somebody who has the clout to get things done, and you have somebody who has the passion to help push it forward through the agency. That's who you want being a part of something like this. And so I always say, let's get that together for leadership. So if you can have that buy-in to get things started, that's really good. You also want to set up what's kind of called a just culture, which there was a great presentation about that I saw about 2 weeks ago. The recording is probably still out there, but there's also a really good article about it. We can send that out, Scott, if people are interested. It just came out. And it's all about, let's say that we have a suicide attempt at our agency, or, there's a death by suicide of somebody. It's not anyone's fault. If we go back and we do a review, it is a systems error. There's a flaw somewhere or several breakdowns in the system that we set up within the framework that we're trying to do. And so it's this idea that nobody's wrong, nothing's wrong, there's no wrong. It's, everything is just, right? And it's about learning. Yeah, it's a learning environment of how to make sure that never happens again. And so it's a different kind of mindset, and it's setting that up so people don't feel like they can't tell, don't ask, don't tell. We want to have, it's just setting up that healthy milieu of wellness, and that again starts from the top and goes down, because we all know that the way we treat our employees is the way they treat the people at risk that are in our care when we're not looking, right? And so it's got to be that healthy milieu, so that people feel comfortable being open and honest, and they don't feel shamed or excuse me, like they can't be open. So it's providing all of that. And then also leadership is about welcoming the voice of people with lived experience, people who have been through the system, or people who have loved and lost people to suicide, or people who have had suicide attempts, to say, for example, we were trying to decide if we were going to have our mobile crisis teams that go out in the night do one of these interventions that we're going to talk about, called safety planning. And we were kind of round and about that. I don't know. I mean, it's nighttime. They meet them out in the field, and we had somebody there who had, and they said, well, I don't know. When I was struggling and I was having suicidal thoughts, I know that would have really helped me. Decision made, done. We're doing it, right? It's going to have that power of being around people who have that lived experience. And so, kind of in a nutshell, that's LEAD. Excuse me, Scott, how much more time do I have? Excuse me.
About 15 minutes.
Okay, great. Excuse me. And so training, of course, is having that skilled and trained workforce that's ready to engage, like I already talked about earlier today, and they have the correct suicide specific trainings. So it's very different than perhaps like a homegrown training that's been made, which can be okay if it's rooted in all of this, and maybe been passed by an expert or something like that, or based on the resources, that I'll show at the end. But it's really got to be suicide specific. That's really important. And identify. So in identify, it's like I talked about just a minute ago, like with the heart care or diabetes care or cancer care, you've got to have that suicide specific screening. You can have a universal screening that might lead to a suicide specific screening, but you've got to directly be able to ask about suicide or you're not going to know. And then an assessment that is based on suicide risk assessment. Not just your normal assessment that you might do on everything. This has got to be specifically around this. And then you can set forth doing your, specific suicide interventions. Excuse me. And so and then that's when you're going to get into the engage piece, where you're going to do like a suicide intervention that's really important, like Barbara Stanley and Dr. Greg Brown's safety plan intervention, which I spoke about. We do that, one of our main interventions with all of our grant sites in New York. And then, the sixth part of that at the end is talking about lethal means and counseling about that and how important that is. So that has to be part of that there. And electronic health records is just a huge piece of making that consistent and congruent across all patients, because a lot of what you're trying to do here is integrate these systems into your practice. And the more that you can automate these things, then the less of a grind it'll be for your staff, and your system. So that can become important. It can, even if you do low tech things, the more it can be automated is the better, so you can have good workflows around these that can ultimately become policies and procedures. And that too can end up being really important. I slipped back into lead there, sorry, and improve. But that's why they're in a circle. Because you going through them all the time. Then you go down into treat, and this is very important. And this is why zero suicide exists in clinical settings. When people say they're doing zero suicide in schools, I kind of, not so much, unless the school has a clinical healthcare setting, which a lot of them do. If they don't, though, and it's just, this is just an example, then they're not doing zero suicide. They can be doing suicide safer schools or something along those lines, but zero suicide has these clinical pieces that it can't just be done everywhere, like the treatment piece. You've got to treat the suicidality directly. And there's only a handful of evidence-based treatment modalities that can do that. And so you've got to make sure that your clinical staff have been trained in those, and then you're going to set forth doing those in this treatment element. And then once that has happened, you go into the transitions and care, which is extremely important as well. That's going to be your warm handoff into the next place. Where are they going next? Are they going home? And then they have to have the warm handoff to the next person who's picking up the care, or what agency, or what group is picking up the care once the care leaves you. There's got to be that overlap like this. It can't just be the care stops here and then it's over here. It's very hard to get the person to go. It's got to be like this, that overlap for the transition and care. That's extremely important. And that happened because you do follow up, phone calls, visits, excuse me, things like that. That's part of like a care plan or a care pathway, or that gets set up with the person collaboratively, and that kind of comes in and engage and treat and transition right there. We call it a suicide care pathway or a suicide care plan, and the family and the person would be involved with that and understand that. Excuse me. There would be an elevated level of care, kind of like I talked about a little earlier. And then basically the improve element, I'm going to collect some kind of data, because we all know if it's not written down, it didn't happen. So if you don't have some kind of data on it, nobody's going to let you keep doing it, because you've got to collect these days. You've got to be able to show that you're doing something with this whole thing. And the other thing is, it's process improvement at its very best, right? So it's about, having this transformational care for people at suicide risk, and, making sure that it's working and happening. Ultimately one day it'll get to fidelity. And so you'll want to have checks on that with your quality folks, right? And so that's the improvement, is that constant quality improvement, is that real-time change on, oh, whoa, that didn't work. This isn't a good, this isn't working in our setting. How do we fix this and improve this? So that's why we want to have measures to look at those types of things around the process and how we're doing with the process elements. But then we're also going to want to have metrics around, some people choose, how many people screen positive for suicide, and that same number of people get a safety plan. That can be a really helpful thing to know. How many people within our system had a suicide attempt? Do we even know that? So there can be things like that that are really helpful. Or are we going to try to track for suicide so that we can know that we're truly helping to bring down the suicide rate in Tompkins County? So some of that can seem really hard and far away, and some of it can be very close to what you're already doing. There's a lot of research behind this. I can leave this for you guys to look through. This is also written by Julie and Mike. I tried to keep it kind of close to the same folks but there's a lot of research out there by a lot of other folks. But I thought that this fit in with everything we were talking about today. And then this is just kind of another thing here. And I can't see you guys very well, so I don't know if you're looking like overwhelmed or bored. And it's okay if you're bored, but not if you're overwhelmed. Actually, it's okay however you are. I just hope that you know that you can all do this. So take a deep breath if it's feeling like a lot. And so this is kind of one thing I've thought about a lot with folks, is if not this, then what? Because we all know you're already treating folks with suicide. You already have staff that probably have training around this of some sort or another, right? You're already doing screening and assessment. You already have the JCO standards coming at you. So that's kind of what these questions are. So what is your plan to address this at a systematic level with your agency? What will you do when the Joint Commission comes through? Do you have a way to know if your patients are getting better in relation to suicide? Are you checking in with them about that? Do you do surveys with them? Are you following up with them after care to see if they've gotten better? Like I said, are you doing effective care in the beginning? Do you know if people come to you for care and they've gotten good care or bad care around suicide? So, these are hard questions and hard choices. You probably have a million things that you're trying to work on at your agency. And I don't want this to feel like just another one, right? That's not what this is meant to be. The last thing we want is to continue to have fragmented systems, without a framework. What this does is it just pulls all this together and it gives it a place to rest. It gives it a way to connect, and it gives your staff a way to connect with it. It gives you language to use. It's all the same. So your doctor and your direct care staff and your managers are all talking the same language, and that feels very good when you're there and on the line, that you're all saying the same things. You have the tools that you need. There's a lot of tools that come pre-packaged, that trainings that come together with Zero Suicide. And so it feels like a lot, but it also feels cohesive. And that's another good feeling. And so, when you talk to staff that have been through this, that at first why do we have to learn something new? We already do so much. Then you go back to them later and they're like, no, I really like it because that screening tool helped me, helped us to figure out that we didn't need so many one-to-ones, or we were really helping the people that needed help and not the people who weren't really positive for suicide, or it helped us use our resources better. And so, yeah, the good news, I really believe this, our current practices aren't far from best practices. You really are already doing this, and you may be doing a lot of this, but so let's connect it together, right? Let's connect it together. And we have people to guide us. We have experts to guide us. We have people with that passion to guide us. The research in the last few years is mind-blowing. We don't have to wonder what works. We don't have to throw the kitchen sink at it anymore. We can know what works, and we can use that. I've tried to show you some of the guiding documents that we have nationally and in New York, and I've got resources at the end. And like I said, we have this flow already going. The Zero Suicide movement is happening internationally, and nationally. It's so accessible. You can put something in the Zero Suicide listserv and hear back from all of these people who write the articles. They will just email you back, so it's just the subject matter experts, the people boots on the ground that are doing it right along with you. Everybody is working together. It's almost nothing is proprietary. Everybody is sharing and helping one another. I said, who can do this? Really, like I said, you can do this. I did this in Texas across 254 counties in a statewide effort with 6 different cohorts over 8 years before I got here. So I've so many different types of organizations that I know that you can do this. Yes, it works. I can't tell you, how many times I heard from staff, how many anecdotal, how many times I've been on calls where I've heard from loved ones. I went out to speak one time in Corpus Christi, and I had a principal come up and thank me with tears in her eyes. And she said, that young man that just spoke, she said, he's alive because of you. And he was on a panel of youth because they had done an intervention with him in the hospital with the Zero Suicide. The hospital had gone through Zero Suicide, and he had crashed his car, but they knew he was suicidal. And they were doing this because they were all informed of Zero Suicide. And the mom came up and thanked me, and he spoke about being suicidal. And he was a beautiful, tall, Black young man. It was very powerful. So you just don't know, you don't know how you're going to reach people or how it's going to work, but it's very powerful. And so just a quick example of success within a system. As I said, Dr. Coffey started with the nurse that stood up and said, perfect depression care would start with no deaths by suicide. So they started that. and their baseline, they had 89 suicides per 100,000 members. They implemented their perfect depression care. Within 4 years, the suicide rate had decreased by 75%. And then that included 2 years with 0 suicides. Now they've been doing it since then, and they've had, let's see, when was that? 2010, and this is 2021. But they've had a cumulative of 10 years of 0 suicides, with rolling years, if you do the statistics. So Brian Amadani also spoke. He's the one who's in charge of this effort now. He also spoke at the symposium, and this is his most recent article. And you can see his presentation. It's really it's absolutely phenomenal. So just take us out thinking about how to get started. Again, it sounds like a lot, and it is, but the most important thing to remember is it is the journey, not, and the destination. It's every little improvement that we make along the way has a ripple effect that is profound. It's actually profound. Every improvement that we make along the way towards this, and everything that we don't do, we're backsliding. And so that's something, to give some thought to. These are some practical steps on how to get started. Developing an implementation team is one of the key things under the lead element. And that's just your good old-fashioned interdisciplinary team. Whenever you start up a new thing at your organization, you always want to get a nice team together, but you want to have representation from different parts of the agency and different departments, not always necessarily the same old players. You might want to throw in some fresh blood, have somebody from QM, have somebody from the floor, have a survivor or somebody with lived experience in there, have somebody from IT, and get the team together to start looking at these materials and this information. There are 2 important getting started things that you can do from the Zero Suicide website. One is the organizational self-study, where you just look at your organization as a whole and where you are with certain base, best practices for suicide care. I love that. And then the 4th bullet point down is the workforce study. And that's where you just send out this blanket survey to all of your folks at your agency, and they just let you know what they know and don't know about suicide. And it's quite wonderful if you've ever looked at it. It doesn't take a lot of time to fill out. And it's basic things like the prevalence of suicide, but it's also some of the things that I said earlier. I know I'm comfortable intervening when somebody is suicidal who's sitting in front of me. I know how to intervene. I have the support of my supervisor to intervene. I feel like I have the training to intervene. Some key questions there that you want to know as leaders. I like to give that and then do some really poignant trainings and some other things like organizationally, and then re-give the workforce survey a year later and see my numbers go up. Because that always feels good, and then you've made improvements. And so these are just some other things I think are important. And then change doesn't happen overnight, of course. There's still much to do. And hoping that this discussion has been helpful, though not much of a discussion, really just me talking at you. So hope you can have some discussion about this. Really, we want to reduce these preventable and tragic deaths. It's really very tragic. And there's opportunities and resources here. You can just look at these when you get this. We have efforts going on in New York. I don't want to take up your Q&A time talking about them. Just like I had said, we have a couple of grants that my team is working on very diligently. We have the symposium link at the end that gets shared with you. We have a guide right here I'll show you that we put together for the symposium. And it's just a basic implementation guide for zero suicide in New York for healthcare providers. Just got a little more information, and it's got our specialized approach that we do in New York, called the AIM approach. So that's in there, along with a lot of other practical tips, and that's on our website, but the link is also right there in this presentation. We have a community of practice coming up. I don't know if anybody on here applied for that, Scott. I don't know if anybody told you that, but is it today the 15th? Yeah, I should know what day it is. But anyways, it's the 16th. I would extend that if anybody here wanted to apply for that. And that would just be to be a part of the Zero Suicide Institute is the National Institute for Zero Suicide. And we are co-hosting this opportunity with them for healthcare agencies that have emergency departments, primary care, and behavioral health within their system, to come with us for a 9-month journey to learn all of the pieces of zero suicide. Each month we would have a meeting for the next, from January, starting in January and going until September of 2022. And so if that's something that your agency would be interested in, there's an application on our website, or I have it here. I would be willing to give you a little bit of an extension on that if that's something you would be interested in. You can email me. And then, nope, that's something that Scott's going to talk to you about. You can look at these resources. Excuse me, they're the ones I talked about, and the phone lines. And this is my last quote. So that's it. Yep. Our final call to action is we were going to communicate emphatically. I generally do, but I don't know. To stimulate, to look at achieving this aim of zero suicide, to help us deal with the public health crisis of the tragic deaths of suicide by our fellow New Yorkers. And I was going to say to type in the chat while we do our Q&A, if you can think of anything that we talked about that's an actionable step or something that struck you even, you know, in the next coming months that you might be able to do to try to, you know, move forward with the call to action.